All right. So, good morning, students. It's a big privilege and honor to welcome you all for this Regain PG for season 2. Today it will be our fourth edition, and we're glad to have the much reputed speaker who do not require the introduction. But I would like to hand over today's session to Dr. Biplab Ghosh, who will be moderating the session, as well as the course director, Dr. Pratik Das, thank you very much for helping us hold throughout the session. So I request Dr. Biplab Ghosh to introduce today's examiner and take the session forward from here. Over to you, Dr. Biplab ji.
Thank you, Mr. Raja. Good morning. On behalf of the panelists, I welcome you all to the fourth session of Renal Classroom. Today's discussion is Dr. Joseph, a DNB trainee from Artix, Kolkata. And we are blessed to have an erudite nephrologist and an excellent teacher, Professor Amit Gupta sir, to be with us today as an examiner. Sir is currently Director and Head of the Department of Nephrology in Apollo Medics Super Speciality Hospital, Lucknow. Prior to that, Sir was Professor and Head of the Department of Nephrology in SGPGIMS, Lucknow. He is the doyen of all fields of nephrology and has a very keen interest on CAPD. He established the largest CAPD program of India and South Asia in SCPJMS, Lucknow. He has authored more than 200 research articles and 30 books on nephrology and kidney diseases and kidney transplantation. He has taught many nephrologists over his illustrious career of over 4 decades. And I'm sure we'll all learn a lot from him today as well. Over to you, sir.
Good morning to everybody. And Joseph, you can start with your case presentation and just be relaxed. This is just only a discussion with 2 intros. So hopefully we'll have a good discussion.
Okay, thank you, sir, and good morning, sir. Sir, I am presenting my case. A 64 years old gentleman, a known case of chronic kidney disease, stage 5 on peritoneal dialysis, presented with cloudy PD effluent for the past 3 days and reduction in ultrafiltration. History of present illness. My patient is a 64 years old gentleman who used to have a grocery store till 10 years back, non-diabetic for the past 20 years, hypertensive for the last 3 years. I would like to begin way back in 2016 when my patient started having a gradual rise in serum creatinine. He was under a follow-up of a local physician and he was told his creatinine was around 5 mg per dl at this time. This was associated with passage of frothy urine and occasional pedal swelling. He also had visual problems by 2017, for which a left-sided vitreous surgery had to be done. He also had signs and symptoms suggestive of peripheral neuropathy in the form of numbness, tingling, and diminished sensation of distal lower limbs. He had poor glycemic control during this time. He was on homeopathic medicines for 2 years. However, he was switched back to insulin by 2019. By July 2019, he had an episode of increased pedal swelling, shortness of breath, and increasing creatinine to 3.5 mg per dl. His urine output was maintained. He was also told to have some protein leak in urine by this point of time. He was admitted at a local hospital for 4 to 5 days. He was told to have increased volume status and improved with conservative management with diuretics. By September 2019, again, he was admitted in our hospital with signs and symptoms suggestive of peripheral neuropathy. He was prescribed some medicines by the neurologist, and by this time, he was found to have creatinine of 5 mg per dl at this time. By February 2020, he had an episode of shortness of breath again, bipedal swelling increasing, frothy urine, nocturia, and creatinine increasing to 6.2 mg per dl. he started to have mild exothermic symptoms in the form of nausea, poor appetite. He was advised for renal replacement therapy by this time, and he has opted for CAPD due to convenience after careful discussion, and he was therefore initiated on peritoneal dialysis by March 2020. The PD catheter was inserted by a surgeon under local anesthesia. There was no procedure-related complications. Flushing was done without complications. There is no record of peritoneal equilibration test done. He was started on 3 exchanges per day of 1.5, 2.5, and 1.5% dual with night dry. He was on regular follow-up and has not been requiring hospital admission in the past 1.5 years. The peritoneal dialysis has been done by family members, his wife, and his 2 sons. The peritoneal dialysis has been done in a closed bedroom. They have a home autoclave. They do not have pet at home. 1 episode of retraining was done after 6 months. There was no issue in inflow or outflow during any period of time. Proper antiseptic care was taken, and daily application of topical antiseptic at exit site has been done. With these 3 exchanges per day, he has been maintaining daily urine output of 1 to 1.5 liter till now. By July 2021, he noticed a crack at the distal part of the PD catheter, which was reconstructed and was manipulated by the PD technician and was advised IP medicines during this time. He then noticed change in effluent color with cloudy changes after around 4 to 5 days. This was associated with underfiltration, and he was advised to take 7.5% of 12 hours duals of icodextrin by night, which he was started at home. This was followed by cloudy effluent persisting and came to us for admission. There was no history of constipation, diarrhea, lower urinary tract or GI tract interventions, or any previous history suggestive of exit site infection or previous peritonitis. The patient had been having daily ultrafiltration of around 800 to 1000 ml per day, in addition to the 1 to 1.5 liter urine output. He maintained his body weight at around 88 to 91 kilo. However, over the last 10 days, the ultrafiltration has reduced to a mere 500 ml per day with even using icodextrin, and his body weight has been increasing to 94 to 95 kg. And a family history. He had 5 siblings, 3 of them were diabetics. No renal diseases exist in other family members. He had 3 sons, no renal disease. The youngest has developed diabetes. And he died. He takes a vegetarian diet. He adhere to the dietary advice by dietitian as practicable as possible. He does not take any extra added table salt in diet. However, he has liberal fluid intake without much restriction. He is a non-smoker. He chews tobacco for the past 30 years. And regarding treatment history, he has been vaccinated against hepatitis B virus. He has been on oral hypoglycemic and insulin and antihypertensive. There is no history of erythropoietin or iron intake. Sir, should I proceed for examination?
Finish off the examination, and then we can discuss the case in full. So finish off the examination.
Okay, sir. Sir, on general examination, the patient was conscious, oriented, and cooperative. There was no pallor. He had edema. There was no jaundice. JVP was not raised. The pulse was 82 per minute, regular, peripheral pulses equally palpable. The blood pressure was 140/80 in the right arm in sitting position. On per abdominal examination, it was distended. There are no scars or previous surgical scars. It was soft, non-tender. The tunnel, there was no tenderness over the tunnel or no discharge or redness found over the exit site. And there are no hernias and there is no hydrocele. The PD catheter is found to be intact. And on chest examination, there is no pleural effusion. Other systemic neurological examinations, he had diminished sensation in the stocking pattern of distribution, as I have stated earlier, and cardiovascular examinations within normal limits.
No, the neurological examination can be a little more detailed. You said some reduced sensations. Can you tell me more? Did you do a detailed neurological examination?
Sir, I just checked for the sensory examination, sir.
What did you do with the sensory examination?
Sir,
Can you repeat the neurological examination again, whatever you have done?
Sir, touch sensation, pin sensation, these two I have done.
So this is diminished in which part of the extremities?
Sir, a distal part, and I have found it to be diminished in the stocking just above up to the ankle. Symmetrical in distribution, both sides.
Symmetrically diminished loss of pain and touch, you're saying, below
Yes,
below the knee.
Just above ankle, sir.
Just above ankle. Okay. Anything else you look for jerks and all? No, because see, he's a diabetic patient. So just you have done these sensory examination. That's fine, I understand. But you need to be also do the other part of the examination, because neurological examination involves examining the motor system, examining the reflexes, examining the sensory system. So it has to be a complete, besides the cranial nerves and everything, and rest of the upper limbs. So
Yes, sir.
if we just say that I've examined only for this stocking area, there was loss of sensation, that is not enough. So whenever you do the examination, they would expect you to have completed the whole thing. Okay.
Yes, sir.
So then in the cardiovascular system, what was the cardiovascular findings in the cardiovascular examination?
Sir, cardiovascular examinations, the apex beat was in the left fifth intercostal space, mid-clavicular line. The heart sounds were normally audible.
No, fifth intercostal space in the mid-clavicular line. And was it normal apex beat, or was there anything different about it?
No, sir, it was normal apex beat, sir.
Normal apex beat. Okay, fine. And then besides that, you see when you do palpation, then you do percussion. First you do inspection, of course, then you do palpation, then you do percussion. So the percussion, you look at the cardiac borders, essentially to rule out any, because it's corresponding to the apex beat or not, to rule out any pericardial effusion. And then you auscultate finally to see if the heart sounds, whether they're okay or not, or there any additional sounds in the form of murmurs or rapper, etc. So whichever system you examine, you must follow the same principles that you were doing when you were MBBS days.
Yes.
So remember inspection, palpation, percussion, and auscultation. Whether it's abdomen, whether it's neurology, whether it is respiratory system, whether it's a cardiovascular system. So
Okay,
in this
sir.
case, you haven't done, that's okay, but in future you must remember to examine this, then you will not miss anything.
Right, sir.
So now can you just summarize whatever you have, then we'll go ahead with the discussion. Please summarize the history and the examination, and then give us your final impression.
Yes, sir. So to summarize, today we have a case of a 64 years old hypertensive diabetic gentleman with microvascular complications of diabetes in the form of retinopathy, peripheral neuropathy, a known case of diabetic kidney disease, chronic kidney disease stage 5 on peritoneal dialysis for the past 1.5 years, with an average ultrafiltration of 800 to 1000 ml per day, with good amount of residual renal function, presented with cloudy effluent of dialysate following a crack in distal part of the dialysis catheter and reconstruction manipulation by the technician, and reduction in ultrafiltration for the past 1 week. There was neither any history of pain and tenderness over the tunnel or discharge on exit site, nor any history of diarrhea, constipation, or recent lower urinary tract or gastrointestinal tract interventions. There was no previous history of any exit site infection or previous episodes of peritonitis. On examination, he was found to have edema. Examination of the abdomen did not show any exit site or tunnel infection, no evidence of hernia or any abnormal fluid collection, and there is no pleural effusion. And he also had diminished sensation in the stocking distribution.
So what is your impression?
Sir, my impression is
in this patient, you said he had retinopathy, but you have not mentioned the fundus in your exam. Did you mention fundus or I missed it?
No, sir, I have not mentioned because patient is already a known case of diabetic retinopathy.
No, that is not this thing. See, if he may be a known case of retinopathy, may have received therapy for the same diabetic retinopathy, but that does not mean that you will not examine the fundus. If the fundus is, you should, if you cannot examine, you should mention that I attempted with the cataract, whatever it is, if you could not see the fundus. But just saying that because he had history of receiving treatment for retinopathy, I did not examine the fundus. That is not be acceptable in the exam. So make sure that you do examine the fundus, and you may be also asked to examine the urine. See that, so make that a habit as well to examine the urine of your patients if the patient is passing urine. And, so unless you make that a habit in the exam, you will find it difficult suddenly to examine, because you'll be expected to examine the urine.
Yes, sir.
So anyway, what is your final impression of this patient?
Sir, my impression is peritonitis in a known case of diabetic CKD stage 5 who has been on peritoneal dialysis for the past 1.5 years.
Can you repeat your diagnosis? You said peritonitis, diabetes, CKD on
peritoneal dialysis.
On peritoneal dialysis. Is that all, or do you want to add on things?
Yes, sir. With other microvascular complications of diabetes in the form of retinopathy and peripheral neuropathy. And sir, ultrafiltration, reduction in ultrafiltration.
and possible cause for the reduction in ultrafiltration?
Sir, during an episode of peritonitis, they do tend to have a reduction in ultrafiltration.
So so we'll discuss that later as to why. So your cause, the possible etiology that you're attributing to drop in ultrafiltration is peritonitis, you're saying.
Yes, sir.
Okay. See, when you give your final diagnosis, you start basically with the basic disease. So his basic disease was diabetes. So rather than starting off with peritonitis, your diagnosis should start that this patient has diabetes. Then you generally try and say which type of diabetes, is it type 1 or type 2? So you start saying type 2 diabetes mellitus, okay? With, if you think the kidney disease is because of diabetes, then you say diabetic kidney disease. Or if you think it's a non-diabetic kidney disease, then you have to try and sort of tell us what is the type of non-diabetic kidney disease it has. So in this case, if you're suspecting it to be a diabetic kidney disease, say type 2 diabetes mellitus or diabetic kidney disease, which has gone into end-stage kidney disease or stage 5D, whatever you say, on peritoneal dialysis, KCAPD, with suspected peritonitis, possibly cause for peritonitis, is it, you think a touch contamination, or is it something else that you're suspecting to be the cause of peritonitis? With ultrafiltration failure, secondary to peritonitis, with the associated comorbidities of diabetes that he has, like peripheral neuropathy and retinopathy, with hypertension or no hypertension. Okay. If you think he is anemic, then you say with anemia or no anemia. So whether he is physically well nourished or malnourished, all that will come into your diagnosis. You understand?
Yes, sir.
So when you make it, then the examiner will get the impression that yes, this fellow has gone through the whole case, and he doesn't have to ask you that, look, what else, what else. That if you complete the whole thing at one go, then it will be good. So in this patient, I just tried to sort of, in your history, you did mention that he was having, he is a vegetarian by diet, and he was compliant with the dietary instructions of the dietitian in terms of salt intake. But is there anything else that you are very keen to know in patients on dialysis, whether they're on PD or hemo, besides the salt intake?
Sir, we should be aware of the protein intake, sir.
Exactly. So that part you did not mention. You mentioned, I'm not sure whether you did mention or not, but I did hear that, I think. You mentioned about salt, which I heard. And you
Yes,
said
sir.
that, but see, your emphasis besides salt is important, of course, and fluid intake is important, yes. But in addition to that, the protein intake is important. Merely saying vegetarian, non-vegetarian is also of no consequence, unless you are sure how much protein and what is the, and you should know what exactly the protein content of various food items, a rough idea. If it tells you that he takes 2 chapatis or 4 chapatis, or whatever he's taking, or dal, half a bowl of dal or 1 bowl of dal, and he takes rice or non-vegetarian items or any egg he takes, so then you should be able to calculate quickly as to the calorie intake. So two things are important. One is the protein intake, the calorie intake, and the salt usage and the potassium, because those are things that need to be restricted. You get my point? So how much protein do you think a patient on peritoneal dialysis needs to take?
Sir, 1.2 to 1.5 gram per kg per day.
Yeah, at least 1.2 grams per kilogram per kg per day to 1.3 grams per kilogram per kg per day. And during the episode of peritonitis, the protein intake, does it need to be increased, reduced?
The protein intake has to be increased, sir.
Why?
Because there is more loss of protein during peritonitis episodes.
Yeah, exactly. So how much protein loss is there generally during the how much protein loss is there during the normal peritoneal dialysis? How much protein loss occurs during an episode of peritonitis?
So normally around 5 to 10 grams of protein is lost per day on a routine peritoneal dialysis. This may increase up to 15 grams, as much as 15 grams per day during episode of peritonitis.
Very good, very good. Okay, let's now go back to your diagnosis that you made of that there is no dispute that he has type 2 diabetes mellitus. We have no
Yes, sir.
dispute of that. But the question you said is that he has diabetic kidney disease. Okay,
Yes, sir.
is that right? So
Yes, sir.
why do you think that his etiology of his kidney disease is diabetes? Is there anything which is against diabetic kidney disease in it?
Sir, considering the temporal course, long-standing diabetes,
Very good.
uh, proteinuria, he had been told to have proteinuria, and with evidence of other microvascular complications of diabetes, I believe this patient is having a diabetic kidney disease.
Okay, so you said that the long-standing diabetes, the presence of proteinuria, the presence of other microvascular complications, you said retinopathy, which you have not checked for actually, and some evidence of neuropathy that he has, which in history as well as on examination you found. But what is unusual about him in terms of his being a diabetic kidney disease? Anything which you found unusual in your history?
Okay, sir. In diabetic kidney disease, they tend to have anemia earlier than other comparing to glomerular disease patients. So this patient doesn't have history of anemia or erythropoietin intake.
Okay, so that's one. That but what about his urine output? He's maintaining a urine output of 1.5 liters. You
Right,
said
sir.
even after 1.5 years staying on peritoneal dialysis. Am I right?
Yes, sir. Right, sir.
So is that the usual thing you've seen so many patients of kidney disease because of diabetes? You
No,
find
sir.
that they maintain a good urine output even till they be started on dialysis, and even after being on dialysis for a long period of time?
No, sir. Usually after declining of the renal function, urine output usually declines as well, sir, in diabetic CKD patients.
So what do you think could be the reason why he is having such a good urine output?
Sir, by the time the peritoneal dialysis was started, he was having only minimal azotomic symptoms, and creatinine was around 6. So he is probably having adequate residual renal function.
So the question that comes to your mind, one is that you're saying that this urine output may not have gone down because he did not have significantly advanced renal failure. Somebody has said in the chat box that is it good glycemic control and may have caused the slowing of the progression of the disease. Well, this good urine output is at the time of start of dialysis. Does it have any reflection on the outcome?
Yes, sir. Those who have residual renal, good amount of residual renal function, they can be started on lesser dose of peritoneal dialysis, and they tend to have better outcomes.
Yeah. So which was that one study that you can remember which suggested the role of the urine output in the survival of the patients?
Can you start study, sir?
Yeah. So what did the Canusa study show?
So in Canusa study, initially it was shown that the KT by V, when it is put at around 2, they tend to have better survival. However, later on, they have found that with a reduction in 0.1 of KT by V, then the survival was decreased by 5%. However, this was later found to be due to the, however, whatever improvement was found to be only because of the residual renal function and not the peritoneal KT by V.
Yeah, very good. So the Canusa reanalysis of the Canusa study actually showed the importance of the urine output, and they found that when they included the urine output in the analysis, they found that for every 250 ml of urine output the patient was having, there was a reduction in the relative risk of death by almost 36%. So that was one of the first studies. Besides, there were several other studies which showed the importance of residual renal function. And as someone suggested in the chat box, that there is this role of the incremental dialysis in such patients. Okay, now let's come to the basic thing that when should we start dialysis in any patient? Or for example, in a diabetic patient, like this patient is a diabetic patient. You said he had minimal uremic symptoms, his creatinine was around 6 or above, slightly above that, and he was started on dialysis. So as a nephrologist, how do you determine when to start dialysis? You have these patients coming to your OPD clinic. They'll come to with various symptoms. When do you suggest to them that now is the time that you should start dialysis?
Sir, firstly, the physical well-being of the patient is utmost importance, whether how his well-being as a whole. Is he having any azotomic symptoms in the form of nausea, poor appetite, generalized pruritus, metabolic control of anemia, and all these things, parameters we have to see.
So very good. So you look at various symptoms that the patient has in terms of his appetite, in terms of fluid overload, in terms of other like uremic pruritus, his whether lethargy, sense of how active he is, etc., etc. But in terms of if you were to give any numbers, say GFR, at what level of GFR would you recommend that we should now, this is time that you should start, even if you don't have symptoms?
Sir, at a GFR of less than 5.
So most people have suggested that you start between 6 and 7 ml EGFR of 6 and 7 is when you would recommend the KDIGO guidelines, and the other guidelines have suggested that between 6 and 7 is the appropriate time. And which was that study which showed that early start of dialysis is not really very helpful? That landmark trial.
Ideal trials.
Yes. The ideal trial which showed that early start of dialysis is not really very beneficial. Patients to, even those who were started later, do equally well as those with early start. In diabetics, do you need to start dialysis earlier as compared to non-diabetics? And if so, why?
Sir, they have to start early because later on the reduction in GFR is more abrupt in case of diabetic patients. And
why? You're absolutely right. But why is that an abrupt reduction?
Because diabetes patients, they have tubular and vascular involvement as well relatively early than those patients with glomerular diseases.
See, that residual renal reserve is less. There's something known as reserve of the patient, the renal reserve of the patient. See, that your ability to withstand any insult, new insult, depends on the residual renal reserve that you have. So in diabetics, it's been seen, as you said, because of structural abnormalities in other parts of the kidney. The renal reserve is reduced. So they can decompensate very rapidly whenever they have this any infection or any other new insult which occurs. Okay, so therefore in diabetics, it has been suggested by some that you may consider starting them on dialysis a little earlier as compared to non-diabetics. Okay.
Yes, sir.
Okay. Now this gentleman was started on peritoneal dialysis. As a nephrologist, would you agree with the decision of the patient as well as the doctor whoever was treating that PD is the recommended modality of dialysis in a diabetic who is 64 years of age?
Yes, sir. One argument is if he has a good glycemic control, then there is no doubt we can carry on peritoneal dialysis in such kind of patients. Sir.
No, I mean, whenever you give some reasoning, you have to base it on some data. So what is there? What is the data to support your whatever you're saying that if he has good glycemic control, PD is a good modality?
Sir, I don't remember, but there was one trial which was showing that even in non-diabetics, only 8% have developed diabetes after starting on peritoneal
the
dialysis.
data is a little old. There's something known as the USRDS data. Have you heard of USRDS? So this USRDS data, they looked at various groups of patients. They looked at gender, whether males, females. They looked at the patients based on diabetes or non-diabetes. And they looked at age-wise, whether the patient was young or old. And they found that based on that, they, of course, their findings have been now contradicted by many other subsequent publications. But what they said was that females do better on hemo as compared to males, gender difference. Second thing, they found that younger patients who are diabetics, they do better on peritoneal dialysis as compared to hemodialysis, the survival outcomes. Okay. Elderly diabetics, according to them, according to that study, do better on hemo as compared to peritoneal dialysis.
Yes, sir.
So this was, and diabetics do worse than non-diabetics on any form of dialysis, whether it's peritoneal or hemo. So at that point of time, when they made this their observations, they said that younger diabetics, they have a better survival on PD as compared to hemo. Subsequently, there have been several other publications which have shown that elderly patients who have associated comorbid factors like cardiac disease are more prone to develop hypotension or other cardiac problems during hemodialysis. May do better with peritoneal dialysis. Now, what are the advantages that whenever you talk to patients about the modalities of dialysis, you have to explain to them that this has this advantage, this modality, and the other one has this. So in terms of peritoneal dialysis, what are the advantages of PD as compared to hemo?
Sir, one thing is the patient can have a more normal lifestyle as compared to the hemodialysis, where one has to spend a certain amount of time in a fixed schedule. And second is that those who have cardiovascular instability, they tolerate peritoneal dialysis more well than the hemodialysis patients. And it is better in maintaining residual renal function comparing to hemodialysis.
Very good. So why do you say that it is better? What is the reasoning that people have given that why residual renal function is better preserved in peritoneal dialysis compared to hemodialysis?
Sir, peritoneal dialysis is more natural form. The ultrafiltration achieved is more natural form than the hemodialysis. Sir, using one, it is more physiological.
Anything else? Anything else?
And there is no exposure to synthetic membrane.
Okay, very good. So why do you think, what does the synthetic membrane do? I mean, does it do anything? I mean, that's a important point that you made. But what does the synthetic membrane do? It leads to some activation of certain factors, which has some deleterious effects.
Sir, inflammation and some.
Yes. So the complement factors are activated. Okay.
Okay.
Okay. So these complement factors, because of these activation of these complement factors, they cause greater or more rapid deterioration of the residual renal function. So that's why people have suggested that the residual renal function is better preserved in peritoneal dialysis as compared to hemodialysis. And are you aware of the importance of residual renal function? Why is
Yes,
it
sir.
important to maintain the residual renal function?
Because the amount of solute removal is much more through the residual renal function in comparison to any
solutes?
form of dialysis.
With solutes.
Small solutes, sir. Small and medium molecules.
Small solutes are removed equally well with dialysis.
Yes, middle molecules.
It's the middle molecules. Okay. Name some of the middle molecules.
So urea, creatinine, potassium, sodium.
The urea, creatinine are small molecules.
Beta 2 microglobulin. Some cytokines.
Okay. Anyway, you read up what is middle molecules and what is this thing. Okay, this gentleman was started on peritoneal dialysis. You state that he was for 3 exchanges per day of 1.5% and of 2 bags and 2.5% one bag. And he was kept night dry in the initial phases, you said. And you said that he did not undergo any PET test. Is that right? If I remember,
Yes,
that's
sir.
what you said in the history. So what is this PET?
Sir, PET is a peritoneal equilibration test, sir,
Why is it done?
So to identify the characteristic of the peritoneal transport.
So what is the peritoneal characteristics that you want to identify?
So the
Why is
patient,
it important to identify?
so the transport status may vary from person to person. They could be fast transporters or slow transporters, and depending upon this, the requirement of their peritoneal fluid and frequency of exchanges may differ in such patients.
Very good. You're on the right track. So you said something fast transporters. So what are the types of transporters that you are aware of?
Sir, fast transporters, high average transporters, low average transporters, and
Sorry,
no transporters.
can you repeat again?
Fast transporters,
Okay.
high average transporters, slow average transporters, and slow transporters.
Okay. So you have, I mean, some people in the earlier, now they have changed to fast. Otherwise, you say high transporters, high average, low average, and low transporters. Just asking you, I mean, it may not be very relevant. You know who was the individual who designed the PET?
Todorowsky.
Yeah, Todorowsky, very good. So Todorowsky designed this PET and peritoneal equilibration test. And how did he come to these 4 groups? Do you have any idea?
So these 4 groups, they have done the peritoneal equilibration test, and depending upon the standard deviation from the mean, they have classified.
Yeah, you're right, absolutely right. Please. Okay, so they did this test in about 830 odd people in his unit, And they looked at the glucose and the creatinine levels, and they designed a formula at 0 hours, 2 hours, 4 hours. And based on that, they drew a curve. Okay. And they said that one standard deviation above and one standard deviation below were considered to be this. They said the main curve was average, and they said one standard deviation above was high average, one standard deviation below was low average, and then two standard deviations above was high, and two standard deviations below is low. So how did this help, this classification of the transport characteristics, help in determining the prescription?
So for a high transporter, they may need smaller exchanges with more frequency or APD, and while patients on the slow transporters, they may
So why would they require more frequent exchanges with shorter dwell times?
Because the osmotic gradient is equilibrated much faster in fast transporters.
Very good.
And
so they equilibrate more rapidly.
Yes, sir.
And generally the equilibration occurs in them in what length of time?
Sir, it is most in the initial 1 hour. Then by around 4 hours, around 90% of urea is equilibrated, and 65% of creatinine is equilibrated by around 5 hours.
So generally it has been found that in patients who are rapid or fast or high transporters, if you keep the fluid, I mean, by 2.5 hours, they generally start reaching the plateau phase. And beyond 4 hours, they start having a dip in there's reabsorption of the fluid, which happens. So yes, in them, you do not keep the fluid in for more than about 4.5 or 5 hours. Because if you keep it for a longer period of time, then the ultrafiltration would be reduced. So they have good solute clearance, but poor ultrafiltration. So remember, yes, good solute clearance and poor ultrafiltration. Whereas slow transporters will have what?
Slow transporter will have slow solute transport, but they will have better ultrafiltration.
Yes, so they have good ultrafiltration but poor solute clearance. So you find that despite doing dialysis, their creatinine still are very high and the uremic symptoms are persisting, but you may have good ultrafiltration. So many of these patients either need to be changed over to hemodialysis, or they will have to do augmented peritoneal dialysis.
Yes, sir.
And the average ones, the high average, the low average, can be continued on PD. Okay. So this patient was kept on day dry, presumably because he was possibly a high transporter. That's why the treating doctor did not keep the fluid in at night. Because if he had kept the fluid in at night, maybe they might have had experienced that his ultrafiltration would go down. Okay. So now this patient, you said, was doing well, and then he developed a crack in the transfer set. Or where did he develop a crack? In the PD catheter?
Sir, he was unable to tell, but what I could gather was it was in a distal part near the adapter, I believe, sir.
Okay, before we go into that, you are quite well versed with the PD exchange procedure.
I have done twice or thrice.
So what is this flush before fill?
Sir, in flush before fill, the Y system is used. The Y connector is used, in which we flush out before putting in the next peritoneal fluids.
Right, you're very right. So first you do what? So because you have to tell your nurse that you do this first, and then you do this, and then you do this.
Sir, we allow some of the fluid to enter to the first limb of the Y connector, And then after that, we close that limb, and then we open the limb of the another limb and allowed to flush.
So first you said that you drain you keep the clamp closed for the outlet for the outflow of the fluid.
Yes, sir.
And you let out a few ml of the solution, runs through the entire bag, so the air is driven out. Okay.
Yes, sir.
And then you clamp the inflow.
Yes, sir.
And you open up the outflow clamp of the catheter so that the fluid in the abdomen is drained out.
Yes, sir.
Entirely. Okay. And after it is drained out completely, then you again close it and again flush the system. And then you again close the drain bag and open up the inflow bag so the fluid runs into the patient's abdomen. So this is flush before fill. And essentially this system was, the flush before fill was done when you had, as you said, the twin bag system developed in Italy by Monpriestini and colleagues. And they were able to show that this could reduce the incidence of peritonitis. Okay. So this fellow, you said that he developed this crack or whatever it is. So if you were called in, see the patient rings you up and tells you that, sir, I've developed this crack. So what do I do? Or the PD technician who was attending to him called you up. So what advice would you give that patient at that point of time?
Sir, if by that point of time there is no signs of inflammation or infection, and the crack is beyond 6 centimeters from the exit site, then it could be cut and freshly connected, sir. Or if there is any signs of inflammation along with it, then it might have to be removed, sir. And less than 6 centimeters.
Okay, but anything else? Because you can't be too sure how 6 centimeters apart. How can you what other advice will you give this patient? Will you like to give antibiotics prophylactically?
Yes, sir. And he has also been advised, sir. This patient has also been advised.
Sorry?
And this patient has also been advised, sir. Yes.
No. He may have been advised, but how many days of antibiotics will you give? And which antibiotics will you give?
Sir, for wet contamination, 2 to 3 days oral antibiotics, first generation cephalosporins.
So for wet contamination, you see, wet contamination means that there is fluid which comes out of the abdomen.
Yes, sir.
Dry contamination means that there is opening up of this of the system without any fluid leaking out. So in wet contamination, you have to administer prophylactic antibiotics for a minimum of 3 days. For a minimum of 3 days. Okay, both gram positive and gram negative. Okay. And it may be important if there's a transfer set which is opened up, and change the transfer set. And when you change the transfer, the end of the catheter has to be dipped in betadine for about 5 minutes, and so that is also sterilized, and then connect with a new transfer set. If it's a dry contamination where there is no leakage of fluid, you may not give antibiotics, though this is again debatable. Some people would, even with dry contamination, consider giving antibiotics. They don't want to take a chance. And you clean that area and reconnect if it's a dry contamination. But if you're not sure whether it's a dry or a wet contamination, it's always advisable to give prophylactic antibiotics for at least 3 days. Okay.
Yes, sir.
Now, you said that this gentleman had cloudy effluent.
Yes,
And
sir.
now this cloudy effluent, what are the causes of cloudy effluent?
Sir, one is infectious cause of peritonitis, and another is a culture negative peritonitis. Then it could be due to some medications, calcium channel blockers, or any IP. Even icodextrin may have some little bit of cloudy effluent. Then some chylous ascites, some malignancies, or any hemoperitoneum.
Okay, so you said one is infectious causes, and you said something that culture negative
Yes, sir.
peritonitis. So what is this term culture negative peritonitis?
Sir, culture negative peritonitis, if the peritoneal fluid which has been taken for examination doesn't show any growth by the third day, then it is deemed as culture negative. And in that case, we have to send the sample from some special cultures and subcultures in order to attain some result.
No, that you will say, but culture negative peritonitis, do we treat or do we don't treat?
We treat, sir. We treat and then we reevaluate with the cell count and differentials. If it is improving, then we may continue. And if it is not improving, then we have to.
So usually the culture negative peritonitis is because of what?
Sir, could be because of faulty in the culture technique.
Okay, very good. So their culture technique may be faulty. And
Could
it's
be
which
partially
is the
treated.
type of organism which causes culture negative peritonitis.
Sir, mycobacteria can cause fastidious organisms, and fungal
Those
peritonitis.
are uncommon causes. Those are uncommon causes. More commonly, it is the gram-positive organisms which can lead to culture negative peritonitis. So what is the ISP, the International Society for Peritoneal Dialysis, say? You said that the culture technique may be faulty, which is absolutely right. So what should be the percentage of patients who can have culture negative peritonitis according to the ISPD guidelines?
So less than 20%.
Yeah, about 15% is what they suggest. Is that 15%? If your culture negative peritonitis rates are in excess of 15%, then earlier they used to say 20%, now they've come down to 15%. And they've said that if you have more than 15% culture negative peritonitis, then either you should talk to your microbiology lab and find out whether the technique that they are doing is correct. So what is the technique of culture, of collecting these samples for culture?
So ISPD is suggesting, sir, we should collect these samples in blood culture bottles, in 2 bottles of aerobic and anaerobic.
Very good.
And to increase the culture yield, they have
But
advised
if you
for.
have if you're like, if the patient is coming into your hospital and you have a good microbiology lab, then you still need to collect the sample in blood culture or bottles, or what will you do?
Sir, we can collect 50 ml and then centrifuge it, sir.
Yeah. So what you can do is that you send the entire bag to the lab as early as possible. And you must tell your microbiologist that he, from the lab, from the bag, he can take a large volume of fluid, at least 50 to 100 ml, and
Yes.
centrifuge that, so that the chances of picking up the yield is much higher. And as you said, that if by any chance you're not able to send the bag to the lab immediately, but if the patient is at a remote place, then he can inoculate blood culture bottles, which you can provide to the patient, that he can be taught how to take a sample from the bag and inoculate the blood culture bottles, which can be brought in to the hospital or to the lab for the confirmation of the diagnosis. Okay.
Yes, sir.
So how do you diagnose peritonitis?
So for diagnosis of peritonitis, two of the following 3 points must be found. One is the signs and symptoms suggestive of peritonitis, which might be a cloudy effluent or uh, pain abdomen. And second is dialysate fluid evaluation showing more than 100 cells per microliter with more than 50% of neutrophils. And third is presence of culture, growth of organism in the culture.
Very good. So you said that 2 out of 3 that the patient is having cloudy fluid, abdominal pain, cell count in excess of 100 with more than 50% being neutrophils, and a culture being positive. So any 2 out of the 3 if they're present. That would be. If a patient is on APD, automated peritoneal dialysis, then what is the length of time that the fluid should stay in the abdomen before you collect the fluid?
So ideally in the classical, I mean in the standard description, then at least 6 hours duels is suggested. However, in APD patients, such time duel may not be applicable, so 2 hours may be enough. And in such cases, absolute count may be not taken into full consideration, and even 50% neutrophils itself may suffice for diagnosis.
Okay. So you said that the minimum period should be about 2 hours. The fluid should be in the abdomen before it is collected.
Yes.
And the absolute cell count may not be in excess of 100 if a patient is on APD. Is that right? What you said? Is that what you said?
Yes, sir.
Okay, fine. Now you find that this patient had come to you with abdominal pain and had come to you with cloudy effluent. What treatment would you start?
So I would start on after sending proper cultures and evaluation. I would start on empirical antibiotics for coverage of gram positive and gram negative, sir.
Now, which antibiotic?
So in our institute, we usually begin with gram negative coverage by either ceftazidime and gram positive coverage by vancomycin.
So you give vancomycin and ceftazidime. So how
Yes.
often do you give vancomycin, and what is the dosage that you?
So vancomycin 15 to 30 mg per kg every 5 to 7 days. It should be given in intermittent doses.
Do you need to monitor blood levels, and if so, what is the blood trough level that you would like to have for vancomycin?
So the trough levels should be maintained around 50 microgram per ml.
1.5.
1.5, yes.
Okay. And you said that the second drug for gram negative you said was ceftazidime. You said, is it?
Yes, sir.
Okay, so ceftazidime, how much do you give? I mean, what is the dosage that you follow in your center?
So we either give in intermittent dose or continuous doses. In intermittent doses, 1.5 to 1.5 gram per day, or in continuous doses, 500 mg per liter in the bolus dose, followed by 125 mg per liter in subsequent exchanges.
Okay. So is there any difference between continuous and intermittent regimes?
Sir, in cephalosporin, it is not found so, sir.
Sorry?
It is not found so, sir, in the difference.
No, but then why do we say that either this or that? I mean, so why don't we, intermittent would be obviously more easier for the patient, give it once and you're done with the day.
Yes, sir. Yes, sir. I think there is one study, sir, which is favoring continuous therapy, sir. I don't remember exactly, sir.
Okay. So because there was some suggestion that in the cephalosporins and the aminoglycosides, maybe continuous therapy may be better than the intermittent. At least in the aminoglycosides, they showed that it's better. But our aminoglycosides, like this patient had 1.5 liters of urine output. Would you like to give aminoglycosides?
It can be given, sir, because studies have shown that shorter courses of aminoglycosides up to 3 weeks may not reduce residual renal functions.
Okay. Any other additional drug that you'd like to give, which is suggested by the ISPD recommendation?
So once patient started on such antibiotics and a fungal prophylaxis may be added.
So they have suggested that you must give fungal prophylaxis for every time you give any antibiotic for any reason. Actually, they're not even restricting it to peritonitis. They're saying that if you give antibiotics, say for example, a common cold, or for example, a tooth extraction, for any prophylaxis, or you're giving antibiotics, or for any therapeutic reason you're giving antibiotics, you must accompany that with antifungals. Okay.
Yes, sir.
Now, this gentleman you said had a drop in ultrafiltration, and you said that
Yes,
his ultrafiltration came down, and in your diagnosis you said that this was caused because of peritonitis.
Yes.
This drop in ultrafiltration. Why does peritonitis lead to drop in ultrafiltration?
So in peritonitis, there is an inflammation, and effective peritoneal surface area is improved in such cases.
Mm-hmm. So
there is more.
Because of inflammation, what happens?
So there is angiogenesis, sir. I mean, and the effective peritoneal surface area is therefore increased because of increased vascularity, and exchange of solute occurs at much a rapid rate, and the gradient is lost faster.
Yeah. So because of increased vascularity, because of new angiogenesis, equilibrium is reached much faster.
Yes, sir.
And see, generally, how does the peritoneal dialysis work? What is the principle of that?
Sir, it works by diffusion, ultrafiltration, and fluid absorption, sir.
So in diffusion, what happens?
Diffusion is, it occurs against the concentration gradient of the solutes.
So the solutes move from an area of higher concentration to an area of lower concentration.
Yes, sir.
And water moves from an area of lower concentration to
higher concentration.
High concentration. So once your equilibration is reached, there will be no further ultrafiltration going on. So because of new angiogenesis, the increased vascularity, this is reached much quicker. And therefore your ultrafiltration would come down when you have an episode of peritonitis.
Yes, sir.
Now, you said that this patient was then changed over to icodextrin and was told to keep it in situ in the abdomen for 12 hours.
Yes, sir.
Why was this instruction given?
Sir, because as the patient had reduced ultrafiltration and he was gaining body weight, this was done in an attempt to increase the ultrafiltration, sir.
Because icodextrin has been shown that the beneficial effects only occur if you keep it for 10 hours or longer.
8 to 10 hours.
Not even 10 hours and longer. Okay. So therefore, whenever your patient is with icodextrin, make sure that the abdominal fluid stays in the abdomen for 10 hours or longer. And then only can you achieve this. Suppose you put in icodextrin and you're not getting good ultrafiltration. What could be the cause?
Sir, one cause could be that there is increased lymphatic absorption of the fluid. Because of icodextrin is absorbed lymphatic.
If you put in icodextrin and you find that this patient is not having ultrafiltration as you would expect, then that could causes that means suggests lymphatic rearrangement. And this occurs in which type of ultrafiltration failure?
Type 3, sir. Type 3 ultrafiltration failure.
And what is type 4?
So type 4 is aquaporin deficiency, sir.
Sorry?
Aquaporin deficiency.
Aquaporin deficiency, yes. Yeah. Yes. So in type 3, there's lymphatic reabsorption. Type 4 is alkaline deficiency. Okay. Now, one last question is that this patient is a diabetic. How do you manage his sugar levels?
Sir, if it is not controlled with conventional, then he can be given on IP insulin to support, sir. And
which would you prefer? I mean, based on scientific evidence.
IP insulin is better, sir.
Why?
Sir, subcutaneous is better, sir. I believe. IP has some issues, sir.
No, but why is IP preferred or better? You're right. You're right. IP is physiologically
Physiological absorption, sir.
physiological absorption, or that's what one of the panelists has said. But what is yours?
I'm not sure, sir.
Because it's absorbed directly. I mean, there's absorption obviously, but there's absorption into the portal system, and therefore it goes into the liver, and there is more effective control of the sugars as compared to administering it in either subcutaneously or taking oral hypoglycemic drug. Now, what is these bad effects of giving intraperitoneal insulin?
So one thing is that higher doses are usually required to maybe up to 2 to 3 times of dose requirement. Second is by repeated handling, it may cause to infection or peritonitis. And third is that, sir, it may cause a hepatic steatosis.
Yeah, steatohepatitis can happen because of this intraperitoneal insulin administration. Now, what is the long term if this patient asks you, so how long can I survive on PD? What would you suggest? Tell him.
Sir, usually
he's already done 1.5 years on peritoneal dialysis. He's been on PD for the last 1.5 years.
Yes, sir. So first of all, depends upon how the present infection goes. And usually by around 8 to 10 years, some patients may have encapsulating sclerosis. And after 6 to 8 years, they tend to have fast transporter status. But however, patient may continue 10 to 15 years or so.
Right.
Without such complications.
Is that future linked to his urine output?
Yes, sir.
And residual function?
Yes, sir.
So would you like to tell him that, look, as long as your urine output is good, your residual function is good, you will do well on PD. But if you start losing your residual function, urine output, you become anuric, then you may need to change over to hemodialysis.
Yes, sir.
In anuric patients, how much of ultrafiltration would be absolutely essential for a patient to continue on PD?
$400 per with So for to get ultrafiltration, then with the modified PET test, he has to maintain 400 ml at least within 4 hours.
There is various studies which have shown that anuric patients on either CAPD or APD, they've said that around 750 ml is the minimum amount of ultrafiltration that should be there in a patient so that he can continue on CAPD or APD. If the patient has less than that, then he should be shifted to hemodialysis because their outcome in such patients is not good. So you have the EPOS study and the NECOSAT study, which have suggested this, as well as the Hong Kong study. And lastly, what are the KTOV that is recommended for patients on PD?
Sir, renal clearance plus peritoneal renal KT by V plus peritoneal KT by V at least 1.7 per week.
1.7. That was the Hong Kong study of YK Low, which suggested this. Okay.
Yes, sir.
So I think because it's already 11:20 and we were supposed to stop at 11 o'clock. Dr. Biplab, shall we stop?
Sir, if you wish, you can continue, sir.
No, I think we
Or
can stop.
we'll go ahead with the session then.
Okay.
We can stop. Pratik is there also.
Yes, yes, sir. This is an excellent discussion. So
Yeah. So
we
there
have also learned well. So
yeah,
I have
there
the
is-
job. Sir.
So anyway, Dr. Joseph, I think you did a good job. But Joseph, you need to sort of, a couple of things is that physical examination has to be more complete. Make sure
Yes.
that you see that the examination they will not accept that you have not examined the full all the systems thoroughly. So fundus has to be examined. Don't forget to do that.
Yes, sir.
If you can examine the urine, that has to be examined. The diagnosis has to be complete in a more structured way. Remember to include all the all the problems that a patient has in your diagnosis. The diagnosis has to be complete, just not related just to the kidney. If he has an eye problem, he has a neurological problem, that also should be part of your diagnosis. Okay, so whenever you present, just reflect for a minute or two before you sort of think that have I included all the things, all the problems that the patient has. Okay.
Yes, sir.
And then the diagnosis will be complete so that the examiner does not have a chance of asking you, is there anything left? Is there anything else? Is there anything else? Okay.
Yes, sir.
Okay.
So
So anyway, it's a good presentation that you made. Thank you very much.
Thank you, sir.
Thank you very much, sir, for such an excellent session. So, Dr. Pratik, this would like to summarize actually
yes,
what you taught today.
actually, yes, I have a job like this. So, Dr. Joseph, we have presented diabetic hypertensive patients with CKD on CAPD for some duration. And now he has presented with an peritonitis and ultrafiltration failure. As San has already told that your examination should be more complete in terms of neurological detail examination. So far, the symptoms are concerned, cardiological and fundus examination especially is very important. You have missed. Diagnosis should be very complete, starting from the basic diagnosis to the presenting problem and comorbidities. And in the history also, you should take the detailed history of the nutrition, not only the salt intake, but also the how much protein he is taking, how much calorie he is taking, and during the procedure. And you should know how much protein is usually lost during the process of peritoneal dialysis. Etiology of kidney disease also very important, especially in the diabetic patients. So there is a diabetic disease or a non-diabetic disease. In those situations, sir has discussed the urine output in this patient. The odd thing was urine output was maintained because the diabetic patients, they have a rapid loss of residual functions due to existing comorbidities, and some trials you have already told that Canusa studies. And another discussion was on the when to start dialysis, not only depending upon the symptoms. Most studies shows that recommendations are around 6 to 7 ml of GFR. And you should know the detail of this ideal trial, whether it's early is better or late is better. And in diabetes, you need to start early or not. That is a question that is to be also needs to be discussed, and should know that. And this is the when you counsel a patient regarding the modalities of the dialysis. This is the US RDS. This is a old one. They have told that some things to be considered, especially the patient who is young, is a diabetic, so they do the better associated with cardiovascular comorbidity. So this is very important For the practical purpose also, when you counsel the patient, when he reaches the stage of CKD stage 5, you should, in this counseling, you should know what are the advantages of PD, what is residual renal functions, and this residual renal function is more preserved in PD because the complement activation is not there due to the exposure to the dialysis system, extracorporeal sustain. And I expected you to mention some of the middle molecules because this is so important. You should remember the names of the middle molecule as well as able to write a short note on middle molecules actually. And peritoneal equilibration test, PET, yes, you have done reasonably well practically at details. And regard starting from the history, what are the types of transporter? I think it is better to tell high rather than fast transporters. And this is the classification is important. And this is what is the characteristics of the high transporter versus low transporter, who do better in terms of ultrafiltration or who do better does in terms of their dialysis. And this is the hands-on experience that is important. You just fumbled a bit. You should do more of the PD procedure, how to do a flushing and what is the flush before fill, that is important. And that is a practical thing. If you have a crack or a history of crack like these kinds of patients, when you should start antibiotic prophylactically in wet contamination, in dry contamination, if you may not give antibiotic as Sir has told you. And how to approach to a cloudy effluent. Not always cloudy effluent means an infections. It can be so many causes, and this can be culture negative also. There is a strict ISPD guideline, and the collection of the samples are important. If you are in a hospital which is equipped with a microbiology lab, in those situations, a whole bag may be a good option to send the sample because the handling by the lab personnel that would be more better for them. Otherwise, there is a fixed guideline to collect the samples. And this is you have told this out of two out of three criteria for the diagnosis of peritoneal dialysis, and how to collect the samples in the automated peritoneal dialysis, where the cycles are very short. And when you get a cloudy fluid, how should you start your treatment? What is your protocol in your hospital, or what are the guidelines? And but you should know in details because you have to practice in your practical life dose of vancomycin, ceftazidime, aminoglycosides that may not cause a residual damage to the residual renal function, but sometimes it can cause the damage to your ear, the cochlear system. So fungal peritonitis is important, and the drop of ultrafiltration, that is a common problem that patient will ask you, especially in the presence of the peritonitis where the increased vascularity and the equilibrium is reached very faster. That's why the ultrafiltration filter is one important issue that is the Sir has discussed. The principles of PDs that are important in all dialysis. You should know what are the principles, or the diffusion, ultrafiltrations, and other modalities. You should know because we are using frequently icodextrin. That is a good information that you should use at least for 10 hours. Other than this, it will not be effective, not get the benefits. And even if with the use of the icodextrin, whether the patient doesn't give adequate ultrafiltration, then you should think of type 3 or the cases or lymphatic absorptions, if I've told correctly. Diabetic control is very important in PD patients. This is one important thing. There's so many trials that's been compared with the different modes, but IP modes have got different advantages. Although it is more physiological, but it has got some advantages because it goes into the portal circulations, and it can cause steatohepatosis. And this is when the patients, if this like this patient comes to, and they can ask you how long you should continue PD, that at least 750 ml of ultrafiltration is required to maintain on PD. Otherwise, you should shift to the other modalities of the renal replacement therapy. And calculation of the KT by V is important. It is slightly different for the hemodialysis, and this is you have rightly told that weekly KT by V, that is important. I think with this time, this was a very comprehensive and informative discussion by Sir, and we have all learned, like all other students, so many things. Thank you, Joseph, and thank you, Sir, for your excellent discussion, so that now we can move forward to the OSCE sessions.
Dr. Ravi, would you
Thank you, Pratik.
start here? sir.
Good morning, sir. Good morning, Dr. Joseph. So next few minutes we'll be going through few 3 or 4 questions, whatever the time will permits. So let us go into the OSCE sessions. The first question is, Dr. Joseph, you can read it yourself or I can read it for you.
Sir, I'll read.
Yes.
64 years old male, diagnosed with HIV in 2008. Medical history: chronic hepatitis C, diabetes mellitus. Started on abacavir and lamivudine, atazanavir and ritonavir. One episode of gross hematuria, empirically treated with antibiotics for a presumed urinary tract infection based on urine analysis. CT scan and cystoscopy were unremarkable. Now presented with left flank pain, nausea, and vomiting.
The next slide.
Creatinine of 2.42 mg per dl, WBC 15.4 into 1040 per microliter, microscopic hematuria. A CT scan of the abdomen and pelvis demonstrated left hydroureteronephrosis down to the pelvic brim. However, no stone or evidence of extrinsic compression was found.
So please see the CT scans provided. There are 2 pictures, A and B. Can you see what is being shown here? Can you tell us the findings? In picture A,
Picture A, left hydronephrosis.
okay. Hydroureteronephrosis, the pelvic part.
Yes, pelvic part is.
Knee is also dilated, and in B,
B also, sir, a pelvic part is dilated.
the arrow is actually showing the dilated ureter down to the pelvis, up to the at the level of pelvic brim. So next slide. So now the urine analysis showed some crystals. Can you say what these crystals are?
Listen, needle-shaped crystals.
Okay.
So could be because of the antiretroviral therapy.
And which drug do you think is responsible?
Could be atazanavir.
Okay. So we can find these kind of crystals which are pins or broom shaped, and probably because of the drugs atazanavir which he was on. Why this city missed these stones or crystals?
So these stones are radiolucent, sir.
Okay. So you have to remember the names of the radiolucent stones which might be missed in radiological examinations. And therefore, how will you manage this patient?
Sir, we may have to stop the drug.
Okay. And then you have to change to some other drugs which usually do not cause crystals or form stones. Anything else for the hydronephrosis part? Your changing of drugs will certainly reduce the possibilities of forming new stones in future. But what regarding the present situation? The patient presented to you with flank pain and hematuria, and the CT showed hydroureteronephrosis.
The relieving of obstruction must be done, sir.
Okay, by means of?
URS believe, sir.
Okay. So as the stone was bit down towards the vesico-ureteric junction, the approach can be done from lower end by cystoscopy and the removal of stone. And if required, the placement of DJ stent can be done if the stone cannot be removed as a whole in a single procedure.
Yes,
So
sir.
the next slide. Now the same patient presented later to you. You can read it yourself.
So the patient underwent left ureteroscopic stone removal and DJ stenting. Few months later, he presented with bilateral edema and both lower limb rashes, which worsens during winter. New onset hypertension, 3 plus proteinuria, RBC 8 to 9, hemoglobin of 6.9, creatinine 2.3, albumin 2.5. ANA, dsDNA were negative, rheumatoid arthritis factor, rheumatoid factor strongly positive, C3 91, C4 1.6.
So what are your impressions? To summarize these details, previous slide, please.
So considering the patient was non-hepatitis C and now presenting with symptoms which worsens during winter, then
So now this is
cryoglobulin,
presented with a rashes and skin rashes, new onset hypertension, and the features suggestive of some glomerulonephritis. Now this patient has proteinuria, active urinary sediments, renal dysfunctions, hypertension, low albumin. Now, regarding the etiology of this glomerulonephritis, you have a very strongly positive rheumatoid arthritis and low
low
complement.
fever. So
So,
cryoglobulin is a possibility.
next slide. Okay. So you have been provided with the biopsy pictures A and B. Can you describe the findings of these biopsy findings?
So there is some showing double contour of the capillaries. And I'm not sure if there is any lobular accentuation, sir.
Okay, right. Lobular accentuation is there in the picture A. How are the vessels? Capillary lumens. Are they cellular? Are they proliferative or non-proliferative?
Proliferative.
Okay, all the capillary lumens are filled up with cells. Okay. In the picture right, you can see some depositions within the capillary lumens.
Yes, sir.
So, what do you think?
The thrombi.
So how these thrombi are formed? These are hyaline thrombi, which are usually, if it is pus, then it is pus positive, or it can be bright red in color in Mason trichrome stain. Though the color has been changed uh, because of the copy paste nature. The exact color is not being shown. So now it's a hyaline thrombi which is filled up, filling the glomerular capillary lumen. Now, what is the probable diagnosis? A
So
patient who is suffering from HIV and HCV and presented with your skin rashes, RA positive, low complements, glomerulonephritis presentations, and the biopsy shows MPGN pattern, marked proliferations, and presence of hyaline thrombi within the capillary lumens. So what is the diagnosis?
So this is probably cryoglobular anemic glomerulonephritis due to HCV.
Okay, you can look into the IF picture which has been provided below. So the IgG is 2 plus, IgM is 2 plus, IgA plus 1 plus, C3 complement plus, C3C plus, C1q 2 plus, kappa and lambda both positive. So how will you describe this situation?
It is full house patterns. All the
Okay, so
panels are positive.
all the panels of IF, DIF are positive. So this is full house pattern. Any other disease you know about where the full house pattern can be found?
Lupus,
Anything else?
MPGN,
Not MPGN, it's IRGN. Somebody has rightly said. Okay, so what further investigations would you do now to confirm the diagnosis?
sir, HCV RNA quantitative.
Okay, you want to look further whether this HCB is again the there are reactivation of chronic hepatitis C. Okay, anything else? How can you diagnose cryoglobulinemia from blood test or serum? What do you see? How will you collect blood? What will you advise your laboratory to do the tests to see for cryoglobulins?
So we have to.
Why it is known as cryoglobulin? These are immunoglobulins. Why the name cryo has been added to it?
So they precipitate in cold.
Okay, at a temperature less than 37 degrees Celsius. So you have to collect the blood at the temperature of 37 degrees Celsius. You have to move that sample to lab at that same 37 degrees Celsius. And then you have to perform the test to cool it down to see for any precipitations. So all these are immunoglobulins. Based on these immunoglobulins, what are the types of cryoglobulins?
There are three types: type 1, type 2, and mixed.
Okay. Can you promptly say what are the types of immunoglobulins in different type of cryoglobulinemia?
So there could be monoclonal,
Okay.
polyclonal.
Yes. So type 1 is monoclonal. It can be IgM or IgG or IgA. Type 2 is a mixture of monoclonal IgM with a polyclonal IgG. And type 3 is both polyclonal IgM and IgG. So how will you manage this patient? This patient is already suffering from HIV on antiretroviral therapy, who is a chronic hepatitis C patient. We don't know yet what is the viral serological viral profile, and now he has developed cryoglobulinemia. In the background of HIV and HCV, how will you treat cryoglobulinemia for this patient?
So immunosuppressions in the form of steroid has been tried, and some rituximab.
No, you please say what will you do for this patient, not in general.
Start on steroids, sir.
Okay. So initially we have to see what is the HCV RNA level, and if there is reactivation, we should start treating HCV promptly. And most of the time, if it is not life-threatening or not organ-damaging situations, the treating HCV and the patient is already on ART, that can help to get rid of this cryoglobulinemia situation. But if it is life-threatening situation, we can simultaneously add some immunosuppressions. And regarding immunosuppressions, which medications have been tried? So can you name some of them?
Rituximab,
Okay,
corticosteroids,
okay,
azathioprine.
Okay. So mostly steroid and rituximab has well been tried, and cyclophosphamide as a maintenance therapy, mycophenolate and azathioprine has also been tried. So for this patient, as this patient is having a renal dysfunction, which is organ involvement, so we'll start treating HCV if there is HCV RNA has increased, and we'll start this patient on steroids. And if patient doesn't respond, we can add rituximab also. Next slide, please. Oh, before going to the next slide, uh, Pratik sir, Amit Gupta sir, Biplab sir, will you want to have some comments on this?
No comments. Yeah, I think you can proceed.
Okay, thank you, sir. So let us go to the next question. Dr. Joseph, you can read it yourself.
51 male, past medical history of nephrolithiasis, hypertension and BPH. Consulted nephrologist for progressive deterioration of renal function, creatinine 1.5 to 2.1 to 2.8 over past 6 months. Had recent hospitalization for pain abdomen and vomiting, and had acute pancreatitis, denied ethanol intake. For last couple of years, he is having chronic bronchitis. He had generalized lymphadenopathy, 2+ proteinuria with bland sediments. USG revealed bilateral and large echogenic kidneys, 12.5 and 14 centimeters.
Okay. So let us go to the next slide. Yes. You have been
Dr.
provided CT scan, right?
Joseph, when you read, you tell the abnormalities also, not only reading, you tell these things are abnormal, then you can make it diagnosis.
Okay, sir.
Just like a summarizations of a case, so that will help you promptly identify the disease.
Sir, 50.
Previous slide.
So 51 male with past history of nephrolithiasis, hypertensive, progressive renal dysfunction, previous admission with pancreatitis, pain abdomen, without any history of ethanol, also having chronic bronchitis and generalized lymphadenopathy. And sonography revealed bilateral enlarged kidneys and proteinuria on urine examinations.
Okay. So this is a kind of multi-system involvement involving the pancreas, the lungs or bronchi, and lymphadenopathy and the renal involvement in terms of enlarged kidneys, nephrotic or subnephrotic proteinuria, and renal dysfunction. Okay, let us go to the next slide. So your CT scan, what can you find in this CT scan?
Multiple hypodense lesions in both kidneys, bilateral.
Yes. So based on the clinical picture and the CT scan provided, what is the provisional diagnosis?
The patient is probably having IgG4 related disease.
Okay. So if you are thinking in that terms of IgG4 related disease, what would you like to investigate further?
Serum IgG.
Okay.
And complement.
Yes.
Renal biopsy, sir, this patient.
Okay. So let us go to the next slide. So further investigations, as you have said, the patient serum IgG is 2,882 mg per dl is high, and IgG4 is almost 2/3 of the total IgG. Serum Ig level is also very high, more than 4,000, but there was no peripheral eosinophilia. And the serum C3 was low, 72.8, and now the kidney biopsy has been performed. So let us go to the next slide. So describe the biopsy findings. A, B, C, D, 4 pictures have been given.
Sir, A is showing clear demarcation of the involved area, 10x PAS.
We can't say PS from this. Okay. So only 2-3 glomeruli and most of the interstitium and tubules, what you can see.
And there are plenty interstitial infiltrate.
Yes. Anything more specific?
Sir, actually, there is a classical description, but I am not able to appreciate it, sir, in this picture.
Okay.
Storiform fibrosis, it has been described.
Okay. So in these slides, you can see it has been written that GC, the germinal centers. So plenty of cells, predominantly lymphocytes and some of maybe plasma cells we cannot delineate from here. And the interstitium is filled with cells forming germinal centers and like a non-epithelioid granuloma. Okay. So some fibrous parts are also been seen in the picture B towards the lower end side. Those areas are fibrotic and less cells. So now, what are the criteria that are needed to diagnose a case of IgG4 related disease?
Sir, histological diagnosis with any of the two among laboratory, imaging, and pattern of other organ involvement. And most importantly, histology requiring more than 10 IgG4 rich plasma cells per hyperfield field.
Okay, actually for IgG4 related disease, all the 4 criteria involving one, clinical involvement of organs in a specific pattern like organomegalies. Second is you need a serological marker of higher IgG and IgG4 level. And the third is the radiological pattern of involvement of radiologically diagnosed. It can be pancreatitis, it can be sialoadenitis, or it can be lymphadenopathy. And the fourth is histopathological. And among histopathological, these findings of cellular infiltrates, storiform patterns of fibrosis, and predominance of IgG4 more than 10 per high power field is required to diagnose a case of IgG4 related disease. So how will you treat this patient?
So they usually respond well to corticosteroids. And I would start patient with a prednisolone.
So usually the prognosis in patients with the renal involvement due to IgG4 related disease is fair, good, or better, and they promptly respond to corticosteroids. If some of them do not respond to corticosteroid, you can think of other immunosuppressive medications also. Okay, so let us go to the next slide. Please read it. Dr. Joseph, can I? Yes.
63 years old male, diabetic, hypertensive. History of parietal abscesses at subcutaneous insulin injection site over abdomen, requiring debridement 2 weeks back. Now healing well. Treated with IV and oral cephalosporin, linezolid, insulin, aceclofenac, and omeprazole. Recent onset SOB and bilateral ankle edema. Presently febrile, tachypneic, tachycardic, elevated JVP, and poor control of hypertension. Creatinine increasing from 0.9 to 1.6 to 2.5 to 3.1.
So, what do you think might be the reasons for renal dysfunction for this patient? You can give a provisional diagnosis and some differentials. So how will you describe the syndromic diagnosis?
So this is AKI could be due to
This is acute.
infection. Yes, sir. Could be infection-related GN or could be acute interstitial nephritis, sir.
Okay. What is the most common clinical diagnosis of AKI in this situation, which we usually find? It's acute tubular necrosis on the
Yes,
background of infection and sepsis. Patient is febrile too. So this can be a sepsis-related ATN,
yes,
or
sir.
else it can be acute interstitial nephritis or infection-related GN. So what investigation would you suggest?
So routine urine examination,
Okay.
complements.
Okay. What do you expect for complements in this patient and in which disease?
So I would expect, considering infection-related GN, I would expect hypocomplementemia.
Okay. Then?
And other baseline investigations for sepsis, hemogram,
Yes.
to rule out procalcitonin.
Okay. So let us go to the next slide. So urine analysis has been done. Sonographically, the kidneys are of normal size as expected, and the urine shows 2+ proteinuria, plenty of RBCs, high amount of WBCs. Both urea and creatinine are raised, and you have C3 level, which is fairly low, 68, and C4 is normal. So now the picture, which has been shown, what is the findings over there? What is the finding, Dr. Joseph?
So urinary RBC cast, I think.
Okay. So this is a cast. It's formed of cells. It might be actually in this picture. This is not. We cannot able to be to say that whether this is RBC or WBC. Because some are WBCs, some are RBCs also. So it's better to say it a cellular cast. It can be RBC or WBC cast. So what are the hypocomplementemic renal diseases where you can find low C3 or low C4 or both?
So post-streptococcal glomerulonephritis, then IgA dominant Staph aureus related infection-related glomerulonephritis, then SLE, MPGN. We may get low complement levels in such diseases.
Okay. So previous two diseases we have discussed also had those hypocomplementemia. You have already said that. IgG4 related disease, cryoglobulinemia, SLE, and the complement mediated diseases like PMA or
PMA.
GN and DDD. Okay. And some non-glomerular diseases where you can find low complements. Can you name some? Non-glomerular diseases with hypocomplementemia.
Infective endocarditis.
That is also a kind of immunological involvement of the kidney disease and involving the glomerular compartments. Low complements, but the disease per se is not a glomerular disease.
Complement deficiencies.
The previous study, the previous case of IgG4 related disease was also a non-glomerular disease with low complement, and as well as atheroembolic renal diseases that also can have low C3. So what next? What will you do next for this patient?
Maybe go for a kidney biopsy, sir.
Okay, so let us go to the next slide. And the biopsy has been done. But what are the findings in the first two and in the last one? What are the findings in the first two and what is the finding in the last one? So
There I so there is
how are the capillary loops? Is it proliferative or non-proliferative?
profile. They look proliferated.
So plenty of cells, mostly neutrophils, filled in the glomerular
Okay.
capillary lumens. So this is a proliferative kind of glomerulonephritis. And that's right on the right side, the electron microscopy, what can you see? Can you identify what is the basement membrane, what is the capillary lumen site, and what are the podocytes? If you can identify all those three structures, you can identify the abnormality. So where the pointer is,
Subepithelial deposit.
yes,
Subepithelial deposits.
so that, yes, so there are deposits which are on the subepithelial side of the basement membrane. So you can identify, you have to identify where the podocytes are, and below the podocytes there are deposits. Okay, so subepithelial deposits are there. So for which disease these findings are fitting in the clinical background of infections and followed by a glomerulonephritis presentation?
So IRGN.
Okay, so it is infection-related glomerulonephritis. Yes. So the deposits are usually on the subepithelial sites in the IRGM and very rarely on the subendothelial sites. And the deposits have some characteristic patterns. So let us go to the next slide. So here you can see the C3 and IgG are positive in DIF. So final diagnosis, as you have rightly said, it's an infection-related GN. Can you say the different patterns of IF in this disease?
It's a granular deposit.
Yes. And these patterns have characteristically been described.
Starry sky.
Yes, people have already mentioned those in chat box. Usually the three patterns of involvement can be seen. One is starry sky pattern, one is garland pattern, and one is mesangial pattern. Okay, so what is pronase digestions for paraffin embedded block, for which is usually being done whenever we see a C3 and IgG, and in the background of probable IRGN, and for what we do pronase digestion. But that will help. How will it help?
So pronase digestion, it will degrade the cell membrane and expose the epitopes.
Okay, so cryptic epitopes gets exposed, and the immunoglobulins which forms bond with other immunoglobulins, that bonds are being broken by pronase digestion method, and the cryptic immunoglobulins that are being exposed. So sometimes we miss the diagnosis and diagnose it as a C3GN. So it's probably not a C3GN. It can be a IRGN, or it can be a monoclonal immunoglobulin deposition disease, MIDD, or MGRS kind of pattern. So we have to identify what the actual type of disease is by doing a pronase digestion that will expose the cryptic immunoglobulins. Okay, so when will you treat this patient with immunosuppression? So certainly you have to treat the infection as the patient is febrile, is probably septic at right now, and you have to treat the infection first. And in which situation you will be going for immunosuppression?
Persistent proteinuria, and if there is any crescent or deterioration in renal function despite adequate treatment of the underlying infection.
Okay, that should be the first one. So if your renal dysfunction is persistent or deteriorating in spite of giving antibiotics and your sepsis has been controlled, at that point of time you start giving immunosuppression. Any other histological pattern? One, you also said if it is a crescentic kind of GN. And third is if there are plenty of exudations and necrosis. So in case of exudative and necrotizing GN in IRGN, we might have to start immunosuppression as soon as we diagnose the case, along
Yes,
with
sir.
treating the infection and sepsis. Okay, thank you. Thank you, sir. So our OSCE session has come to an end, and over to Biplab sir and Pratik sir.
Well, thank you, Ravi. This is a very good session today. Joseph has done reasonably well. It is much more than our expectation, and Sir is excellent, and OSCE sessions are also very
excellent session. I think I would like to congratulate Dr. Ravi for sort of doing an excellent session, and we have learned a lot. I mean, I think one of the best sessions I've ever attended. Very well done.
Thank you.
So, Biplab, can we conclude today's session?
Yeah, please. So, thank you, Amit Gupta sir. Actually, it's the other way around. We learn a lot from him, a lot from you, actually, sir. And thank you for sparing your time. And over to Mr. Raja for closing this session.
Sir, Rajesh sir is having some network issue. He has messaged me. So I'll thank all of our panelist members, especially Dr. Amit sir. Thanks for sparing your valuable 2 to 3 hours time last Friday and this Sunday also. Thank you very much, sir. And Dr. Pratik Das sir for starting this course, and Raviranjan sir and Biplab Ghosh sir to moderating the session and asking the OSCE session. So we'll be having other session in upcoming days, and I'm posting one information so that everyone can approach us for becoming as a discussant in our upcoming session. So thank you and have a great day. Thank you all. Namaste.
Thank you.
Thank you, sir.
Thank you very much.